Disclaimer. This program is intended for informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The following program is intended for mature audience only.
Hi, I'm Dr. Kathy Swain Jones.
Hi, I'm Dr. Denise Joseph Zollicoffer.
Hi, and I'm Sonia Williams Finney.
And this is
Menopause Diaries, Real Talk, Real Stories.
Hi, everyone. Welcome back to the Menopause Diary. Boy, are we glad to have you here. And if you have not listened before, you're in for a treat today. As you know, Menopause Diary, it's real talk, real stories. This is when we do a deep dive into menopause and we partner with you through your journey. If this is your first time, welcome. We're so glad that you have joined us. And today we have such an informative session. I know every time I say we have an exciting podcast today, but you know what? Every time we talk, it's exciting because we're bringing to you new stories, new ways of looking at things that you may never have heard before. So we're really glad, and we're here to make sure that this is informative, interactive, and that you feel like you're a part of our podcast. So without further ado, I want to introduce myself. I'm Dr. Denise Joseph Zollicoffer, nurse practitioner. I'm joined today by my partners. Dr. Kathy, would you just introduce yourself so they know you're
Hi.
here?
Yes, hi, I'm Dr. Kathy Jones. Great to be here again today.
Great. And my other partner, Sonia Finney. Sonia, go ahead and
Hi, how are you?
So that is Sonia Finney. And, as we're doing this journey into the menopause issues that we all have had in our lives, we realize that some women are complaining of pelvic floor issues. Now, what are pelvic floor issues? So, vaginal dryness, painful intercourse, urinary incontinence, all those issues are things that we have heard from our patients as Dr. Kathy and I have been in practice, and we're talking to our friends and we're realizing that these are real issues. Normally, we bring on just regular listeners who want to share their story. But we thought today it would be very good and informative to bring in an expert who can deal with some of these issues and really share with us some solutions, at least options that we can have. So today we are joined by Lottoya Manderson, and she is a pelvic floor physical therapist. And this is a really, relatively new area in medicine and treatment of menopausal symptoms is pelvic floor physical therapy. And it's really, really exciting and interesting. And as I have talked to Lottoya, I realized, boy, this is exactly what we need in order to help our listeners and ourselves through menopause. So I'll tell you briefly about Lottoya, and then I'll have her jump in because we want to make sure we're using our time wisely. She has had 16 years of experience treating as a pelvic floor physical therapist. She's board certified in women's health clinical specialist, and she is certified in pelvic floor rehabilitation. She treats, women with pelvic pain, urinary incontinence. She uses things like biofeedback, electrical stimulation, ultrasound therapy to help her clients. And she's also a member of the American Physical Therapy Association. Now, without further ado, I would like to introduce to you Lottoya Manderson. And Lottoya, why don't you start by telling us a little bit about, the who you are and pelvic floor physical therapy, if there's anything further you need to add about who you are.
Hi, Denise. Hi, everyone. My name is Lottoya, as Denise just said, and I have been a physical therapist for 16 years. I've been doing pelvic floor therapy for about 13 of those 16 years, just getting different certifications and preparing for my board exams and stuff along the way. And have had the wonderful opportunity of working in a hospital-based facility where I was able to see a myriad of different kind of patients suffering from pelvic floor dysfunction, ranging anywhere from your typical urinary incontinence, or I shouldn't say typical, but a little bit less complex, to patients that are cancer survivors and are dealing with the different effects of whether it's radiation or chemotherapy, post-surgical patients, patients with GI dysfunction. And, it's been a great opportunity to be able to serve my community in that sense. And a lot of people kind of think that pelvic floor therapy is just really about Kegels. And I've been really happy to say, that we're slowly trying to dispel that myth that it's not just you doing Kegels. In fact, there are many situations where Kegels are not warranted. And it's just a little bit more in depth, and knowing that there are options, more conservative options for things like pelvic pain, dyspareunia, vaginismus, endometriosis, chronic constipation, people who are suffering from urinary frequency, urinary urgency, that medical options are great, but conservative management can also be a step before that medical option or surgical option.
I'm glad you talked about that, because I honestly just thought when I hear pelvic floor exercises, I was thinking that Kegels were the only thing. So I'm glad you explained that too. You brought that up, because I know that for me, that's the one thing that I thought, that was all that existed, was the Kegel exercises. So thank you for sharing that.
Yeah.
And just so that we are leveling the playing field, you mentioned a couple words that I want you to please define: vaginismus and dyspareunia.
So vaginismus is a form of dyspareunia. So it's a condition where it's painful intercourse. So dyspareunia itself, it's the term they use to refer to painful intercourse, usually penetrative intercourse. And so vaginismus, it's a condition where the muscles are inside the vagina, the pelvic floor muscles, they go into spasm, and they don't allow for easy entry or easy penetration. There's a lot that surrounds that. It's not just about the penetration, but in order for intercourse to be pleasurable, you have to be able to naturally lubricate, or to be able to get those glands to open to secrete those natural lubricants. And in situations of vaginismus, that's not almost impossible, because the glands stay really closed because of the muscles that are inside the vagina just are in a hypertonic state, and it doesn't allow for easy penetration, and not just even intercourse, but even situations where we're just doing vaginal exams and trying to get a speculum on these patients. It's like, you might as well be torturing them. So it falls underneath the umbrella. Vaginismus falls underneath the umbrella term of dyspareunia.
Wow. That was helpful.
Yeah. Was that ringing a bell there, Sanjay?
Yeah. So, I mean, I just want to ask, so wait, so as a therapist, so you're saying when the gynecologist inserts the speculum, not when you do, like you don't.
Right, no, I do not use speculums.
Oh, okay. So I'm like,
Yeah.
wait a minute. So they're doing, okay. So yeah. Okay.
No,
So
it's usually one of the complaints that I'm hearing from patients, like, just even vaginal exams.
So when they've gone for their pap smear, then they come in and they say, oh, it was painful when the doctor, because I've had that experience as well.
Yeah.
But okay. So yeah. Okay.
And a lot of times that's how they get referred to me. A lot of times they're in their GYN office and they're trying to get this exam done, and that alerts the GYN that there's something more going on.
Because it's so painful. Yeah.
Yeah. Okay. From a gynecology standpoint, there are patients who would have dryness, and that might be their issue. And then there's patients who might have it's like a muscle spasm of the entry of the vagina. Mm-hmm. And then there are patients who have both. And so that's when it gets interesting, and you've got to figure it out. And some just call it one thing, treat for one thing, and never look back. And the patient, goes without having that knowledge that maybe something underlying is going on.
Wow.
Yeah, I think, being in practice, how many times have I seen a patient and not even with exactly that, it's painful, and not really even understanding that there was an option for them for pelvic floor physical therapy, which is why I'm so glad that you have joined the podcast, because how many people out there did not know that this is treatable and that they can get some relief from the symptoms?
I know I've seen at least 3 or 4, well, 3 for sure, gynecologists in the last couple of years. And with my issue of incontinence, severe incontinence, that was never offered as a possible solution. So I'm so glad to have you here to get my questions answered directly. So
Well, Sonia, bring on the questions throughout the podcast, because whatever you're asking, I'm sure there's someone else out there who's asking the exact same thing.
Mm.
Well, Latoya, you want to continue and tell us how does pelvic floor physical therapy work?
So typically, you do not, in the state of Florida, you don't have to have a prescription from a doctor to come in and see a pelvic floor therapist. In most states, it's at this point we have direct access. So most states now you don't need a prescription. However, it is nice to have a diagnosis that is codable and that it's billable. So a lot of times you will get a patient coming in from GYN or you're a gynecologist, your primary care physician, your colorectal doctor, depending on what the condition is. That when you come in for an evaluation with me, I typically try to get a good history of what's happening, some of the social aspect of it, because we know that stress is a huge component that plays a big role in a lot of this stuff, especially even in urinary incontinence or urinary frequency. Anxiety and stress, improper stress management can really play a huge role. And just trying to get a history of, their past medical history. Are they taking blood pressure medication that may be a diuretic, that may be resulting in them going to the bathroom very often? So getting a good history is kind of key, and just listening to the patient. What I found in my practice is that I get so much, I don't have to ask a lot of questions if I get the patient just talking about it, because this is, unfortunately, it's a topic that it's not spoken about as freely. It's a topic that so a lot of people don't know who to speak with. Do they speak with their primary care? Do they speak with their gynecologist? Do they go to a urologist? Or they're not really sure. So when they have the opportunity to sit down and someone listens to them for an hour, they go to town. And so I do a lot of listening, and they tell me a lot of what their symptoms are, and getting an idea of when this started and what are things that they have tried, and what are things that exacerbate their conditions. And once we've gathered that information, then we go down to actual objective examination. So the examination does include just kind of looking at the person from a holistic perspective and not just going straight at their pelvic floor. I check the alignment. I check a lot of times they're coming in with multiple complaints. So there's usually low back pain in addition to urinary incontinence, because there is some weakness component that does translate to spinal malalignment and spinal instability. And so we'll look at their alignment. I look at the muscle strength. I'll look at their flexibility. I'll see if their hip is mobile or if it's not mobile. And then we then go ahead and do an internal examination. And an internal examination is definitely not as in-depth as an OBGYN examination. We're not going to the point of the cervix. We're really just assessing the inside of the vagina. For a male, because I treat male and female, and male patients do have this issue as well. For male, we go intrarectally. We go through the rectum and we assess the muscles that are inside the pelvis. We're checking for tone. We're checking for areas of tightness, areas of pain, tenderness. And then I have them, this is where the Kegel comes in. I'll assess their strength. I'll see if they're able to do a Kegel, because a lot of times people come in and they really don't not know how to do a Kegel. And their concept or their perception of what their body is supposed to be doing when they give it that command to contract may be the complete opposite. I have many patients who come in and you ask them to do a Kegel and they do a pelvic tilt, or they squeeze their glutes together, or they are bulging and bearing down and pushing out, because that's the strongest sensation that they can feel, especially if the muscle is weak. they're going to do what they feel is the strongest thing. And so that may be bulging, which could be making the problem even worse, because that's kind of what you do in order to empty your bowels or your bladder. And once we get a good assessment of what's happening in terms of, the patient being able to properly do a Kegel, we're checking their strength, we're checking how quickly they get tired when they contract those muscles. And then we go ahead and put together a plan of care for them. There's a lot of education involved. The bladder is trainable. So if we're dealing with a situation like urinary incontinence, there's a lot of suppression techniques, stress management techniques, informing them on things that are irritating to the bladder. So like caffeine, carbonated drinks. A huge one that we don't really think about a lot is like artificial sweeteners. That's huge in terms of irritating the bladder and causing urinary frequency or having someone go to the bathroom pretty often. Checking their water intake. How much are they really getting in? People will always say, oh, I drink plenty of water. But then when you break it down in terms of how much they really need to hydrate, that gives a better, they'll say, well, I guess I drink 2 bottles, 2 16-ounce bottles, but that may not be anywhere near where they need to be in terms of proper hydration and for good bladder health. So, we definitely teach them some suppression techniques, how they can take back control of their bladder, how to train the bladder to do something different than just answering the call every time you get this signal to go to the bathroom.
So, not just carbonated drinks, but diet sodas are pretty bad for us as far as.
I always say to patients, you know what, just go drink. If you're going to drink soda, just get a glass of soda, because the diet's probably worse. Because here you go, you have the carbonated plus the artificial sweeteners. So it's like double whammy.
Wow.
So
I never thought of that. Go ahead.
So Lottoya, was it Sonia? Were you saying something?
Well, yeah, go ahead. Because I have a whole, I've written down. She said,
No,
so
you go ahead. Because
I didn't want to interrupt her while she was talking, because there were so many questions that I had just as
go ahead.
Going through. So just real quickly, first of all, so you said that there's no referral needed to seek this type of therapy. Is it covered by insurance, or is it?
So it's a good question. If you're going to a hospital-based facility, you may need a referral. Okay. If you're going to a freestanding clinic, you don't need a referral. If you're going to a private practice, you do not need a referral. But and it depends on your insurance as well. So a lot of freestanding clinics, my practice, my cash-based practice, and a lot of the freestanding clinics are cash-based. But a hospital-based facility typically do take insurance. And there is, depending on the policy of the hospital, a lot for liability reasons, I guess, they will go ahead and request a referral from a doctor. And it's also someone in order to kind of keep that communication with and be take that team approach. So they want to be able to have notes to send to the doctor and kind of go back and forth with, the doctor being in on this patient care and being a part of the team, of the healthcare team.
Okay. And then you talked about the connection with back pain, and when you're doing the assessment and checking for alignment and things like that. Is that something that's very common? Because I'm not going to say how old I am, but I actually have been literally, when I think back, I've been suffering from incontinence for like literally about 15 years now. And so I know you're saying that, no, it's not something that you commonly talk about. It's not something that you want to share. And so I can imagine that when people come in and they find, they come in to talk to you, I know that I would have a wealth of, information to share with you, because it's been going on for so long. But is that something that's common? Because I still suffer from back pain, lower back pain. And I'm wondering if the two were connected at some point as well. Is that very common, or?
It is very common, actually. And it's because I always refer to the pelvic floor muscles as the hidden core, the forgotten core. The deep core muscles that really are the first line of stabilization for your spine involves the pelvic floor muscles. The muscles that really count, that really helps to keep the spine moving and in the way that it should, or stabilizing when it needs to be, are muscles we can't see. And the pelvic floor is a huge one. Our diaphragm is a huge one. How we breathe affects our back, our alignment in our spine, and how our muscles is going to kind of come in and take some of the stability, and take some of the work off of the actual vertebrae themselves. So yes, I guess let me not go off on a tangent here, but yes, the muscles, if they are typically weak, these are the same muscles that do help with supportive function. And so they are not only acting to control your bladder, but they're also helping out in stabilizing the spine. So if your muscles are weak and you're resulting in urinary incontinence or issues of prolapse, which that's a whole other issue, then it's safe to say that it's going to result in decreased core strength. And decreased core strength is usually one of the big things for lower back pain. Apart from the obvious things, like if you do have a disc herniation or a nerve impingement and things like that. But even that also has to do with the muscle's ability to keep the spine stable. Because if it's not, then you have this shearing force that happens, and then you start to get some disc herniation, or you increase the risk of disc herniation.
Okay. Thank you. I just want to make sure that all of our listeners, that they're saying that there's so many different things that are connected to this. So, as I have, but yeah, that's helpful. So, and hopefully some of the other listeners that are out there listening may, say that, wow, I've had this incontinence and I've had back pain, and they can, see that there's a correlation there. So thank you for sharing. Yeah.
Yeah. To piggyback on that was kind of answering, what I was going to ask was sort of what Sonia was saying. Do you find that a lot of the weakness that you see that happens to a woman otherwise who didn't have problems in her late 20s or 30s, and it starts around 45 is from childbirth or pregnancy? And can you kind of say a little bit about how some of those changes are not detected, but then maybe later on some of the imbalance or the weakness comes?
Yeah, I could get on a soapbox about that, Kathy. It's my belief, and it's my greatest desire for that every woman who have had a child needs to have at least one assessment with a pelvic
Yes,
floor.
ma'am. Yes, ma'am.
Yes, ma'am. I truly
it should be
that.
A part of postpartum
really
care. Period.
It absolutely should. So much happens during pregnancy with the pelvis. This is the house that holds this baby that's ever expanding and ever growing. And all these bones, all these, muscles and ligaments and tendons are stretched beyond capacity. And then if you were to have vaginal delivery, people have very similar issues if they had C-section, because of the 10 months of carrying this baby and the strain that the pelvic floor muscles, which it's a perfectly named muscle, because it really is the floor of your body, and it really is holding things up. So when you have been pregnant for 10 months and you're carrying this heavy weight, these muscles are going to be strained. It's like walking around, and holding, 25-pound dumbbells and walking around all day, every day with it. Those muscles in your arms are going to be sore. So yes, we do see quite a bit of weakness from pregnancy, but you mentioned 45-year-old and people, and I'm approaching 45 myself and starting to experience some perimenopausal symptoms. And one of the huge component of that is the fact that our estrogen starts to get, dysregulated. So, in menopause, when you have this dysregulation of hormones, those hormones estrogen is like, testosterone for women. We need estrogen in order for good muscle strength. And when we start to see this drop in estrogen, we start to get muscle atrophy. And this it's not just limited to the muscles in our arms and our legs, but the pelvic floor muscle. The reason why pelvic floor therapy kind of falls underneath physical therapy, because we're supposed to be the muscle experts, and we're dealing with the muscles that are inside the pelvis. They go through the same processes as the muscles that are in our arms and our legs, the one that are more readily seen. So hormone imbalance does play a huge role in causing some weakness of those. Did I answer that question, Kathy?
Oh, absolutely. Absolutely. That's exactly what I wanted to highlight. Yeah.
That's interesting too. And I found that I probably, Kathy's spot on, because again, I said I wasn't going to tell my age, but I already told you how long I've been suffering from incontinence. So at some point you're going to put the math together and you're going to figure out how old I am anyways. But I say all that to say that I was in my 40s when I started to experience these issues. And to hear, you talk about it in that manner and think about it from a pregnancy standpoint, and you are, and what goes into, I'm thinking about pushing out my, and I had vaginal deliveries twice. So, and I've often wondered, but I didn't think of it from that standpoint as you're speaking about it. I actually thought there may have been a correlation or something related to the epidural that may have caused, but hearing you say that, I mean, it makes complete sense. Like you're saying, I mean, this is the area that has housed this baby and this child. And so, I mean, that puts a whole nother perspective on it. Like, I'm like, oh my gosh, I never thought about it from that perspective. So yeah. I mean,
it's the physics of it.
It is. Yeah.
You've got a tight basket.
Yes.
And then if you stretch it out, it comes back, but it doesn't come back to the original. And I know that, and I've got 30 years in, Lottoya, and I remember early on in my career, and I happened to kind of come through that time where a lot of doctors early on were doing a lot of C-sections. So we were trained, hold out, push them, go longer, push them through. And to watch some of the damage of a 110-pound lady passing a 9-pound baby for 26 hours because the baby was okay. But what happens to the mom afterwards? And so I was one of the first ones early on to start doing pelvic floor reconstruction on women once they said, I'm done with my children. Because what I watched happen was women who would start leaking a little bit after pregnancy. They could kind of hide it. And maybe after that third baby or so, they're leaking at 35 or 40. And the pelvic floor damage is beginning to affect the marriage. Then divorce happens, and then the woman is coming in crushed and it wasn't mentioned back then. It was taboo because the thought was, you're fine. When you're in your 50s, we'll fix it. Right. And I thought there's just no way we could leave somebody like that.
Yeah.
And so I did that for years. And actually, I love native tissue repair. I went through all the meshes and all of that, but native tissue repair is the best. And certainly women, I believe looking back, the best would be, it needs to be a part of the last obstetric visit is you now go, and I'd say probably, a month of, at least, 2 or 3 visits to get that pelvic floor back where it needs to be. And then to take some proactive responsibility at the time of delivery on, yes, your baby came out, but what does that mean for you? Because when the bladder's down, the rectum's down, and the marriage is gone, you have to think about those things. So I know you've seen that.
Absolutely.
Yeah. Have you seen women who come in and you say, you probably need to go back to the urogynecologist or look into surgery ahead of time because of the degree of
in cases like I'm sorry, I didn't mean to cut you.
Oh no.
In cases where the grade of prolapse, and I just did a talk on this yesterday about pelvic organ prolapse, and basically that's where the organs that live, just for our viewers out there, the organs that live within the pelvis, like your rectum, your vagina, your uterus, your bladder, even some of the intestines, starts to fall in or sag in onto the pelvic cavity. And in severe cases, they start to actually bulge out of the body, depending on the kind of pressure that you put when you're having a bowel movement or even peeing. Depending on the severity of a prolapse, if I have a patient and they come in and before I could even have them bear down or do anything, I'm seeing that the bladder out pouching and coming out of the entrance of the vagina. At that point, can physical therapy help? It can help to reinforce the surgery. Mm-hmm. So at that point, typically what I will say to them is, there are some surgical options for you. Maybe a pessary can be a short-term help, and pessary is just basically a tension-filled device that you put into the vagina to kind of create some tension and put things back, push things back where they're supposed to be. But that also comes with a slew of challenges, with its own set of challenges. So if it's a situation where the severity of the prolapse is so bad, I have definitely referred them back to the GYN and say, let's talk to the doctor about some surgical options for you. And one of the urogynecologists that I worked with for quite a while, she would send the patients for therapy before, knowing that she scheduled the surgery, but she would do some strengthening through the muscles, because a lot of times, especially if it's a sling procedure, they're anchoring those things into the muscle. And so if the muscle have a good amount of integrity and the muscle is already strong, it's going to, those surgeries are going to be more successful, and they're not going to fail as easily. And then they'll do the surgery and then send me the patient again after, because sometimes after the surgery, you just went in and you did surgery. That's traumatic to the pelvis. And sometimes, we have patients that have pain issues, and depending on their pain response, a lot of times people will guard, or people will kind of clamp down, or people will go into spasm just dealing with the pain. And physical therapy or pelvic floor therapy is a really nice option to help them to manage that pain and help to relax and lengthen the tissue as necessary. And then also go ahead and try to further strengthen the muscle to try to reinforce the slings. I hope that's what.
Absolutely. And here's one of the other things that I think that is important is a lot of times. So after surgically managing a lot of these patients who would come to me after seeing doctors for years saying, well, the doctor said I was fine. It's normal after having a baby. You can actually go in and your finger falls into a finger long, finger deep defect where the episiotomy was cut, repaired superficially, because doctors a lot of times aren't trained to go in and do a good urogynecologic or pelvic floor reconstruction. And they should be. And there are a lot of, non-doctors delivering patients who haven't been trained on how to really, stabilize that pelvic floor. So they will still just kind of do this. Everything looks fine, but with relations, it does that because that little connection is gone. Right. That I was always very sensitive to that. So, yeah.
Kathy, I can literally hear people going, aha, she just mentioned something that is me right there.
Yeah.
And it's talking about the episiotomy.
I was just
breakdown.
Say that.
Yeah.
I was going to ask a question about that. Go ahead, Denise. I'm going to see
the breakdown of the episiotomy and how that relates to, that pain, really painful sexual intercourse. And is that something that pelvic floor physical therapy can treat for the pain resulting from a breakdown of an episiotomy?
Well, there's two things though. It's the pain that they may feel, and then the lack of stimulation they felt before having the baby. And if you're looking at episiotomy as several layers deep, what happens is those superficial layers are sewn, but not the bottom layer where the fascia is that is in the pelvic floor. So it looks closed, but it doesn't act closed. And that becomes the problem. And so in my mind, and Lottoya, you may feel the same thing, is that that could be that could be changed by just a better training of episiotomy closures.
Yes, I agree 100% with that. And I think that because, as you said, it looks like it's healed. It looks like everything from the visual eye is seeing this, but then you see a change in the function because the muscle haven't been addressed. And if that muscle still has somewhat of a tear, or if it even has healed, it's not going to have the same integrity. It's not going to have the same kind of strength.
Like this. It'll do that.
So we look at, that's something that we assess when we're doing a pelvic floor assessment. We look at the laxity of the different walls, especially on the bottom wall off the vagina, and seeing how lax it is. So we kind of press in like you described.
Yeah. And take your finger and see if it rolls and drops. If it drops in that cavity and it's buried,
Yeah.
Yes, physical therapy ahead of time would help, but I would encourage them to see their physician. And if the physician
Right.
says, no, that's normal after childbirth, have them see somebody else or
Yeah.
encourage them to do that.
Yeah,
Because
absolutely.
this is one of those things that we don't have to accept.
Yeah.
You know what I mean? That's one of the biggest things, moving into functional medicine and not doing surgery anymore. Those were my favorite surgeries because those surgeries gave women their life back because they've been discounted for too many times that this is normal. It's the way, and they don't feel real penetration. And then there's concern with the partner, and it really causes a lot of dynamic shifts in the relationship.
Yeah.
So
And to answer
question
that
about
question about where the role of the pelvic floor therapist in that, we're not doing surgeries like Kathy mentioned, but I think what's more important is being able to recognize and diagnose that there's something going on and it's not in the patient's head.
That's right.
And a lot of times they're just validating that there is a real issue here. And the patient doesn't understand that. They don't know what's going on. They're not trained.
Because they've been told that they've been
Exactly.
told for 10 years before they saw you. They've been told from 28 to 38 that there's nothing they can do about it.
Absolutely.
And they're embarrassed.
Yeah.
And I bet there's a lot of people who see you and they come in for their leaking urine, but that is also on their mind, but they've been programmed. There's nothing we can do about that.
It. Exactly. Yeah.
So and forgive me because I don't judge me, but question. So I have two children. I had a episiotomy with one and not with the other. Which and what determines whether or not that's necessary? I guess.
The episiotomy.
Yeah.
Well, that's determined at the time of childbirth if the obstetrician or whoever's delivering the baby feels like there's enough anterior and posterior room for the baby to get out without a significant tear. So ideally, the pelvic floor massage. There's a lot of techniques you can do. Pelvic floor massage, perineal massage, to help accommodate for those babies coming in, or for the baby coming out. But that is, it really is patient dependent on who should get a episiotomy. And I guess probably more the issue is the repair of the episiotomy or the patient who should have had an episiotomy and did not have one.
Okay.
Or the patient who should not have even delivered vaginally.
Both of my babies were very small. I had a 5-pound baby and a 6-pound baby, so not big babies, but I know that I suffered tremendously from the one that I couldn't even move. My bottom was so sore after that episiotomy, and it took me. I thought I can't even. In thinking about it, I would never want to go back to that pain, but.
There's physics of the pelvis, where the sacrum and the pubic bone sit, and I don't think that that's monitored enough to make sure that who is at your bedside that's going to deliver you understands all of those dynamics. I would bet a physical therapist would understand those dynamics a lot more than people who are doing deliveries. And so then they end up with the disaster when it probably could have been prevented with just knowing the mechanics of the pelvis.
And that's one of the reasons why I think it's growing big time, where pelvic floor therapists are supporting women through their pregnancies.
Yeah.
And so, and I've had just a few patients deliver this year, actually about 3 patients delivered this year that I worked with throughout their entire pregnancy, and just preparing them for birth. And just, like you said, there's some women who probably shouldn't, just based off their body mechanics, they probably shouldn't have been a vaginal delivery candidate in the first place. But I think if there are things, they're finding that there are things that you can do to prepare the birth canal a little bit more so that you can avoid episiotomy. Just do like perineal massage is something that's a simple, it's a simple technique, but some people don't know how to do it. But if they're taught to do it, different exercises to kind of lengthen the ligaments that hold the pelvis together. So like, your sacroiliac ligaments and things like that. There are different stretches and positioning and things like that that we are now instructing women on doing in preparation for the birth, so that the first time that they are expanding the pelvis is not when they're on the operating table, or when they're on the delivery table, I should say. They're doing this stuff at home in a more controlled environment where they're comfortable, and they're lengthening, they're opening, and allowing for a lot more distensibility off that pelvis when they're delivering. So I think that we're really trying, and I say we because I'm trying to speak for the pelvic floor community, that we're really trying to be more proactive in during, not just after delivery, but during pregnancy and up until delivery. And even, they have therapists who are right there along with the mom sometimes, and if the hospital or the birthing center or wherever they are allows for that, just to kind of help to support them through that and make that delivery process a little bit easier.
Is that something that you do or is available? And
Yeah.
do you or could you possibly have a phase of it, the 2 weeks before delivery or so, where they come in just for pelvic floor, stretching and massage to
Absolutely.
just loosen those muscles, loosen those, same way you do if you have a cricket in your neck,
Yeah,
or
absolutely.
if you had, some type of, is that available now for patients?
Yeah, absolutely. I work with patients through different phases of their pregnancy. I have people coming to see me from day one. Well, not day one, but the first trimester. Yeah, maybe the first trimester, especially those that are in the athletic world and would like to continue to work out and do what they'd like to do safely. And then I have moms who are coming to see me right at the very end, right before, when they're experiencing some of those pregnancy related pain. And typically that's what they'll come in to see me for. It's like the lower back pain, the sciatica, the round ligament pain, all that they're experiencing at the end of pregnancy, or just the discomfort of having this baby and your posture changing. But those patients, I definitely work on releasing those muscles and kind of preparing them for birth, and not just addressing the pain that they're here for, but I address some of the concerns leading up to delivery and helping them to feel a little bit more confident in actually going through the delivery.
Yeah, I think that's just key, because the amount of time that I did deliveries, it can be devastating and life changing if it goes wrong and the pelvic floor is not prepared, and there's the stretching or the undetected tears, and to be able to prevent that, I think women would really support that service.
Yeah.
If they knew about it. If they knew about it, attached to the women now who are at 45, who could say, had I known that, I would have gone in for 4 weeks of, or 3 weeks of pelvic floor therapy to prepare, to minimize, because it's all physics, to minimize that damage. And so a lot of our listeners may have daughters who are preparing for that, and can pass that information along, especially if you have had a pelvic floor issue yourself, or leaking, or know somebody in the family that could benefit from that. Because I think that would be a service, if it's unserved right now, would be something, a little niche that if we educate proactive on, here's where you could end up, and that end up is real. And the thing about urogynecology is, like, when I started, there was me, and I trained with the guy who trained me was maybe 2 hours away, and he would come into the city and operate maybe every 2 or 3 months. So you have to save up your patients. They'd come in, and then I, trained for it. And so I did it for years, because I watched how many women were, that's an underserved population that doesn't have to be.
Just to kind of piggyback on that, I've had so many women that are currently in menopause who they literally will say to me, I've been having this issue for a very long time. Ever since I had kids, I had some leakage, but I put on a pad And I kind of took care of it that way. I never really thought, I was told that this is what happens after you have a baby. When you laugh, cough, or sneeze, you'll never be able to laugh, cough, or sneeze the same way. You can't jump on a trampoline without having some leakage. And so many women have normalized this or have been told that there really isn't anything that they can do about it. And so this kind of carries on into their later years, where now we have this estrogen loss, and now the muscle is really suffering because you don't have the same kind of, you don't have the fuel that the muscle needs in order to keep
the
it.
little thing that was holding it together has now begun to atrophy. And that's why when we put them on the hormone replacement, it helps, and it helps most women. Doesn't help them all, but if it doesn't help you completely, there's an undetected tear. And I'm going to say it again. If your doctor says it's normal part of menopause, just nicely, kindly thank you and find somebody else.
Absolutely.
Which is why it's so good that we are educating people about this, Lottoya, because they can find you. They could find someone like you. So if I were a patient and I came to see you for a consultation, and you decide that you would take me on and treat me, what can I expect from a course of treatment?
So the first thing is education. Just, knowing what's happening and trying to put the patient's mind at ease that this is not something that is in their head, whether we're talking about painful intercourse or we're talking about urinary incontinence, or it's not something that they have any control over. A lot of times when I see a patient, they come in with the mentality of, that my bladder pretty much took control of my life. And so that the first thing you can expect is to be empowered, that nope, we're going to take back control of this thing. We're going to get you to take back control of your bladder, not your bladder control you. Mm-hmm. And so, and I find that in doing that, patients become a more active part of their treatment and in their rehab journey. There's a lot more, they'll do the exercises, they'll do the work that they need to do because they know that they're partnering with me in getting this and getting back some control over their life. And so education is the number one thing. I take them through, I have my anatomy model, I have my pelvic model. I'm showing them the muscles that we're working on. I'm showing them what's happening when these muscles aren't working properly. And then again, do an assessment, and then we put together a treatment plan. So in terms of time frame, it really isn't, it's patient dependent. It depends on the chronicity of the problem. So it depends on how long they've been dealing with this. The therapy can take as little as 6 weeks, or it could take as much as 6 months, depending, and it also depends on what it is that we're working on. The body has a way of falling into habits, and especially when we're dealing with pain, and our response to pain, we tend to guard, and the body starts to think that that's the normal state that it should be in. So trying to change that signal or trying to change that message can take a longer time than trying to just strengthen a muscle that's weak. So it really is dependent on the condition that I'm treating that's going to determine how long a patient's going to need therapy for, or how many sessions. In my practice, I treat patients once a week because, like I said, I want to put a lot of onus on them. I want to make sure that I give the information, I give them the tools that they need to do to manage this. And I want to give them back some power and not depend on just me and what I do for them, but more what they can do for themselves. And some of the things that, I've had patients who I'm treating for urinary frequency. And honestly, the problem is not something mechanical. The problem is a behavioral thing where they were told that every time they get the urge to go to the bathroom, they should go. They should answer that call, not understanding that the bladder has the capability to hold up to 3 hours of urine comfortably. And they hold too long. A lot of my patients are school teachers, nurses. Yeah.
Or doctors.
Ones that are holding, they say after this next patient, I'm going to go. After this next patient, I'm going to go. And they don't ever go. And so they're holding and over distending the bladder for 5-6 hours. And now the bladder itself gets weak. That's a whole other issue from pelvic floor weakness. When the bladder is weak, that's a detrusor. That's an involuntary muscle. That is going to need medication. There is no exercise in the world. You could Kegel from now until the moon. It's not going to fix a weakened bladder. So a lot of it is behavioral changes. And so sometimes, I see a patient for 3 visits and I teach them how to practice proper bladder health, how to properly empty their bladder. Instead of hovering over the toilet, sit down, because then you won't kink off the bladder and you won't of the urethra, and you will be able to properly empty, so that the bladder doesn't fill back up as quickly and you feel the urge to go within 30 minutes again. So just teaching them how to properly empty their bladder, teach them how to down regulate. If they're an anxious person or a very stressed person, they're a type A personality and they're walking around completely clenched, teaching them how to relax and getting them to be able to sit down and properly empty their bladder sometimes goes a long way. Or just teaching them how to suppress those doing suppression techniques where they've trained their body to empty every hour. Okay, let's now train it to empty every hour and 5 minutes, and then take that up to every hour and 10 minutes, and giving them tools that they can actually apply to their everyday life, because some of the things that they're doing are just natural things that they, comes naturally to them, or they were told that this is what you're supposed to do. So I don't know if that answered the question, Denise, but
it really does. But we've only touched on the bladder. So what if I come to you and I'm having painful sex and I really want to have sex? So how would that look as a treatment plan?
Denise, before we move on to that, can I ask a question about the bladder, the weak bladder versus the urinary frequency or incontinence? So, so it sounds like are those 3 different? Are they and I'm just asking because
I should clarify that.
all of them.
I know
you could have one or all or more.
Yeah.
Okay. So
I know I opened the bag.
For the person like me that's listening, so can you just give a quick or what's the difference between the 3?
Okay, so you can have where the muscle is compromised, right? Where the muscle is either too weak or too tight. Okay. And a lot of times it's both. So it gets a little bit confusing. If the muscle is too tight or in a hypertonic state, or they're guarding and the muscle is in spasm, it's going to be weak. Okay. Or you can have a patient that experience stretch injuries like pregnancy, or where they're pushing or straining, and the muscle ends up being really lax, and then it's weak. They're both gonna result in difficulty holding your urine. So when you increase the pressure, whether from laughing, coughing, or sneezing, or jumping, or pushing, or pulling anything, that's going to override your ability for the sphincter that actually controls the urethra. So it's going to override its ability to hold it, and so you don't have leakage. And that's what happens when the muscles are weak. Now, when we talk about the bladder itself, the bladder can get over distended, where the muscles that are in the bladder, the detrusor muscles, can get to the point where they're not having that same recoilability. So it's like you have a rubber band and you stretch it out, and it just doesn't have the same kind of stretch response that it should. And it's that stretch response that we need for the brain to recognize when we need to empty. And if that's not happening, and the brain isn't getting that signal, or the brain is getting too much signaling because it's being, the bladder is in a state, we call it's like a fibrillation, where the bladder is hypersensitive and it starts to kind of fibrillate, then the brain's going to constantly get the signal, I gotta pee, I gotta pee, I gotta pee. And then the person thinks, okay, then I have to go. So that's a urinary frequency, or we usually refer to as an overactive bladder, where the bladder is literally in a spastic state, and it's giving this extra signal to the brain that he has to go. Now you have a neurogenic bladder. That's a different story, where the nerves that go to the bladder just not working the way they're supposed to, and they're not giving that signal to empty. And so the bladder could be over distended and getting all this urine, and that can happen from habit of holding for so long that now you start to get some nerve injury that what the body depends on for you to know when you need to empty or when you need to hold. That signaling, it gets disrupted because the nerve isn't working the way that it should. I feeling like I'm going down a whole different.
No. You're good. I mean, no. I mean, I'm telling you, I'm learning so much, and I hope our listeners are too. But so, and in my situation, so if I am sitting, like I could be sitting in my bed reading at night, and I can literally have to go to the bathroom like anywhere from every 30, 45 minutes, like consistently, from just sitting, go to the bathroom, and I'm emptying because that's the other thing. I'm like, well, I'm wondering, and when you're saying, are these people, when you're saying you have the urge, or are these, when they have the urge, are they actually going to the bathroom, or are they just feeling like they have to go and they go and there's nothing there? Because when I go, I go. So I can literally go to the bathroom over the course of a night, 6, 7, 8 times. Just waking up, either if I'm sitting or either just from waking up at night. And I will say though, that I haven't had that experience in the last couple months, thanks to Kathy, who gave me some awesome recommendations with, just in terms of I was using an estradiol cream, but using it a little differently. She had me, Kathy, I don't want to steal your thunder. Do you want to say it, tell what you had me do, or because it worked tremendously.
Yeah.
It changed my life. I'm telling you, it was life changing, because when you go to sleep at night and you go to bed and you're waking up constantly every hour and a half to go to the bathroom, I could be in bed for a total of 8 hours, but if I'm waking up all through the night going to the bathroom, I'm not functioning at my best the next day.
Yeah.
So when I did that, I was like, okay, I'm going to try this. When she first told me I was going out of town, and I'm like, no, I don't want to do it then, because I'm like, I'll just wait till I get back. So I literally did her little 14 dose regimen loading thing, and she'll talk to us about that, I guess. But it worked. And when I tell you that having uninterrupted sleep is a beautiful thing, when you have not gotten it in forever, I mean, it's life changing. So I did that, and I've noticed the change. And so now though, I'm kind of noticing, and I'm like, okay, I still can go, like I may get up once a night, which still for me, I will take any day over waking up, like I said, every hour and a half. It just makes a huge difference. But and so I was just wondering, with some of your patients, when they're waking up at night, are they actually, and I'm trying to figure out what category I fit in. It sounds like maybe weak bladder, because I mean, I'm literally going, when I get up to go to the bathroom, there is literally something in it. And I'm not even drinking more water throughout the night, but I'm still getting up, going to the bathroom. Or either I just have gotten to the point where my bladder's not emptying completely, so I'm going more frequently, or I don't know, but yeah.
Kathy, you want to?
Well, what I would say with that is when, so the bladder can be multifactorial. There could be several reasons. And so it's like, unpeeling an onion. And so there was certainly some atrophy there. That's why you responded. So the sphincter that holds the urine in was probably saying, I can't hold even just a little bit. When we strengthen that and strengthen some of the muscles of the pelvic floor, that gave you some help. But there could be some other underlying, and there's some testing that now needs to be done to see what's exactly going in. Are you having no urine in and your bladder's just overactive from a neurologic or muscular standpoint?
Right.
And so this is how the process goes, is that we start with maybe the most obvious. So based on the fact that there's still something there, I think the next step would be maybe having, I don't know how you would do it, but maybe like a urodynamics test done, have the overactivity ruled out from a muscle standpoint, because that can be retrained also, but it's better to know than to say, well, let's try this now and let's try this now. So Lottoya, what's your take on that?
I was about to say the same thing. Honestly, I think that's when you now start to have to do the testing. The urodynamic study is a great place to start and to see is the bladder actually emptying. You're able to see some of the pressures, the juicer pressure, the sphincter pressure, all those things. You're able to get a good idea of what's happening with that person because it is multifactorial. It could be some of my patients are getting up and they're telling you, I'm peeing. I get up 8 times, but urine is coming out. And my response to that is always, you know what, the bladder is never truly empty. It's never
because it's a circuit.
Right. It's so once your kidneys are working and it's filtering and you're getting that work, it's never truly empty. So you'll always have something come out if you go and sit down and you relax enough, it will come out. So it is multifactorial for sure. There are different things that I think this next step would be to try to figure out through testing, what is it, the bladder and the muscles surrounding the bladder that there's an issue with, or is it a pelvic floor issue? Is it a strength issue? Is it just like a behavioral issue? A lot of my patients I have do cognitive behavioral therapy because they just their anxiety levels and everything just results in the clinical manifestation of that being they have to pee very often, or they're not emptying properly because those muscles are clenched so tight that sphincter can't relax enough to empty the bladder. So in that case, even though they get some urine out because the pressure behind it has lessened, but if that muscle is spasming and is cutting off the flow of urine, they're going to fill up back really quickly. And so once their bladder fills back up again and they get that urge to go, they're going to go to the bathroom again and they're going to have the same response because the muscle is in a spastic state and it's really not allowing for proper emptying of the bladder. So I would agree with Kathy. There is a little bit more to consider when you're trying to figure out the exact cause. And the good thing is there are testing that are available to kind of come down to a root cause of what's happening.
And what I would suggest, Sonia, is a urogynecologist and not a gynecologist. That you'll do that visit and they'll send you on to the urogynecologist. The exciting thing is there's so many treatment options now. And combined with pelvic floor physical therapy and the treatment options that are available doing the testing, typically there is a treatment for it that can resolve your symptoms in most patients.
Well, I mean, like I said, and so I'm going to be coming to see you, Lottoya, and Kathy, I'm a work in progress with you. So,
yes.
But again, and let me just say too that not just nighttime going to the bathroom, the treatment that your regimen. So it's helped me during the day too. So let me just add that. So it wasn't just the nighttime. I mean, I was going to the bathroom 1,000 times a day to the point where I didn't even want to go places because, like you said, it's embarrassing when you're like in a meeting, you're sitting with people and you got to get up and, say you're at a meeting for 3 or 4 hours and they're like, well, dang, didn't you just get up and go to the bathroom? Like, I got to go to the bathroom again. Like, and you don't want to. So you try to come up with an excuse like, oh, I think I want something to drink because you don't want to say, oh, I'm going to the bathroom again. Yeah. So, I mean, it's embarrassing. And then I know we got to move on, but the only last thing I wanted to ask the question is because I hear a lot of people say, like people laugh, cough, sneeze, but for me, it's a little different. And I don't know how many listeners are experiencing this. So mine isn't like the cough or the sneeze. Mine is just like the urgency. So like if I have to go and if I don't get to the bathroom right then, I'm going to have a trail of just leave a trail of it. You're going to know exactly my steps because I just can't hold it. So I don't know if that, if that's different or
So
that's just
that's falling under the category of urge incontinence. And to be honest with you, don't feel bad. That is the hardest thing to treat. It's a lot harder than stress incontinence because with stress incontinence, then I know that there may be an issue of weakness. And if they strengthen the muscles and teach them, techniques to help to suppress that, it may work. But with the urge incontinence, a lot of times, the bladder quickly develops patterns, and so, or habits. So if you always answer the call, when you get that urge to go, you always answer that call and you're going, then all that happens is over time, that call starts to come in a lot faster and a lot quicker, and your body starts to respond exactly that way. And so it becomes this like cycle of, okay, that 30 minutes now drops down to 20 minutes because the body figured, okay, she answered the call to go. So as soon as she get this first desire to void, and not that strong sensation comes on a whole lot quicker than that first, when we're 18 and we get that desire to go to the bathroom. You're like, oh, I can hold it off. I have to finish this paper or what I'm doing. We call that the first desire that you kind of ignore. And then once the bladder starts to fill more and it starts to get a lot more full, then you start to get a stronger urge to go. And that's when you start to figure, I can't really hold off anymore. I have to go. But even then, you're able to do techniques. Some people, they do the pee-pee walk, we call it, and they're squeezing their legs and they're doing all this stuff to get them some of these muscles to help out, to hold it so that they don't empty. But after a while, if you answer the call every single time you get that urge, that first desire and that strong desire gets closer and closer. They're not two separate things anymore. They become where it's just that first desire is the strongest desire. And so there are things that we have to take in mind where we start to think about the nervous system and think about, is this person in a sympathetically driven state that they're constantly getting this, or they're in a parasympathetic state. And so when we get that urge to go and you start to panic and you start to think, I have to go to the bathroom, I have to go there now. Now, all these signaling that's sent to your brain to hold gets really disrupted. The brain doesn't know what to do anymore because you're thinking about peeing. The body is experiencing this desire to go. And so you're running to the bathroom and all that's happening is now it's coming down. So it's really a matter of what are the things that we trained our body to do, and how does the nervous system start to get disrupted, and how do you regulate the nervous system? And so medications, sometimes, like anticholinergic and stuff like that does play a big role in helping to calm some of that down. And then there are a slew of different treatment options, but also, like I said, the cognitive behavioral therapy and just teaching the body to react differently to those urges. And so that you don't go into the cycle of where, the bladder starts to now take control of you and you're not being able to control it.
Well,
I wanted to say something real quick about medication, because sometimes when we say medication, women won't go to the doctor just because they think, well, I don't want to it's not worth me being on a pill every day. It's really not. A lot of times it's not a pill every day. You might take it. We do what's called bladder training, retrain your bladder. So you would take the medication daily, maybe for about 3 months. And what that does is progressively stretch out those episodes that you have to go to the bathroom. So say now you can hold it 3 to 4 hours. And just like Lottoya said, your body begins to kick in and remember, oh, this is what I'm supposed to do. And it kicks back into. So it's not necessarily medication you have to take forever to get the effects. It's a part of a retraining of your bladder. Yeah. So it would be something that but you want to do the urodynamics first to make sure that that's something that you would need. But the medication can be very helpful in a compliant patient who's willing to, do the work and allow the medications to, because the medication basically just blocks the urge to go. It blocks that signal. And so you're able to hold longer and longer.
Yeah,
well,
and that was really helpful.
We don't want her to go.
We're out of time, but you know what?
Well, we're going to do a part 2.
No, I think this was so helpful. Yeah, no, I hope that our listeners learned something, and I mean, I know I did, and I still could go on, and I'm hoping with the information that I learned from you guys today, I can shed my nickname for some of my friends was Pepe Le Pew, because I couldn't hold my pee. So maybe I could eventually get my bladder and pee under control, so I'm no longer Pepe Le Pew or whatever they call. Yeah. So yeah.
Lottoya, it has been so good to have you on, and we have to bring you back.
Because
I would
there's
love to be back.
yeah, I'm writing stuff down because I'm saying, oh, we haven't touched that yet, and we need to get to that. And plus, I know you also had a case presentation, which was very good, that I think would be very helpful for people. But before we go, could you share your contact information so if our listeners want to get in, a consultation with you, they can.
So my practice is LMC, pelvic floor rehab and physical therapy. I am located in Cooper City. I do by appointments only. So that's on my card. You probably won't see the address, the physical address for the place, but my contact information is Lottoya at Gmail. It's spelled Lottoya at gmail.com. And you can also contact me via phone at 917-204-2300. Yes, I still have my New York number. It's the only way I hold on a little bit to that New Yorker in me. But and I know people see that number, they're like, it's a spam. But
Can
it's
you repeat
not,
your
again,
number again, please?
I'll repeat it. It's 917-204-2300 or Lottoya at gmail.com. And my office is located in Cooper City, but along Griffin Road and Nob Hill. But like I said, I go by appointments only. And once you get in touch with me, we'll talk and do a brief little consult. And then we'll see if I'm the right fit for you or if you're the right fit for me. And then we'll go ahead and get you scheduled.
One more quick question. Sorry.
Yeah.
One more quick question for our listeners that are not here locally in Florida. Is there a organization or some way they can look up and find like pelvic floor?
Absolutely. Yes, the APTA is the American Physical Therapy Association is the kind of the housing body for physical therapy in general. But on the APTA website, if you go to the sections on women health, there is a directory that has information state by state, and it has a list of therapists and their different qualifications. Now they're different, and I have to point this out. I don't want to sound discriminatory, but there are different therapists have different skill levels. So finding someone who can work on men, children, neurological issues, your more complex issues, you're probably going to want to see someone that has a board certification in women's health physical therapy, because there are different levels of certification. Some therapists are only certified to treat urinary incontinence. Some therapists can only do pain. Some therapists don't treat male patients at all. I personally like to treat male patients. But on that website, under the sections on women's health, there is a directory, and you can find state by state and the therapist and their contact information. They try to keep it as updated as possible. If you're looking for a woman of color, and some people, for some people that's important. There is a woman of color PFT directory that you can go on and look up as well. And then that directory also lists state by state the providers in your area that are women of color, or even, Spanish speaking. Some people feel much more comfortable with someone that can speak to them in their own language. So on that website, on that directory, we have, right now we have about 100 and something members on there. That a pelvic floor therapist that can provide these services across the state.
Well, thank you so much. I will be calling you. You
will be hearing from
me very, 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 very soon.
Yeah, and I just wanted to say to our audience, because of, I did a lot of pelvic floor reconstruction, bladder surgeries, worked very closely with pelvic floor physical therapists, and Lottoya is one of the best in the sense that your depth of knowledge. So I just want to encourage all of our patients or clients or anybody listening to this in Florida who might need that service. And even if you don't nearby, even if it's an hour drive to see her, it's well worth it, because what happens is there's a lot of people who have degrees and certifications and licenses, but everyone's not the same. And in most of my experience in a department, you'd find one that's the person to go to. And I would say that she would be the person to go to, instead of just picking somebody out of a book, because your results are only as good as your therapist, and she's one of the best. So thank you so much.
Thank you.
Lottoya, we're so happy to have had you here today. And I know that you do virtual and all that stuff. When we bring you back for this part 2, we definitely need to go into that, because a part 2 has to happen. And if you like this podcast, if it's been very helpful for you, please share it with your friends, your neighbors, your enemies, anyone. Let's get the word out, especially to our community of color, as we are so underserved in so many ways. So it's so good that here on this podcast, we have 4 women of color who are talking to you about issues that are important to us. So Lottoya, stay tuned. We're going to bring you back. Listeners,
Thank
please.
you, Albie. I love, this is my, bread and butter. I could talk this stuff all day, every day. So
Yes.
anytime, just let me know. I am very willing to come back.
Thank you
Thank
so
you.
much. Thank you so much.
Bye-bye.
All
See
right.
you guys next time.
See you next time, Lottoya. See you
All right,
guys
take care.
next time. Bye-bye.
All right. Bye-bye.
This is Menopause Diaries, real talk, real stories. Thanks for listening. Let's thrive together through every hot flash, mood swing, and sleepless night. Don't forget to like, share, and subscribe to Menopause Diaries, real talk, real stories. If you have questions or want to share your story or would like to be a guest, visit us on Instagram at Menopause Diaries Podcast. Let us start a conversation and navigate this journey together.